We would start off with Dr. Sunil GANEKAL, who is the Chairman and Medical Director of the Davangere Nethralaya Super Specialty Eye Hospital at Karnataka. And he's going to be showing us another case of a dialysis and how interestingly he managed it differently. On to you, Dr. Sunil.
Good afternoon, ma'am. Hope I am audible.
Yes.
Okay, let me give a brief introduction about the case. This is a 52-year-old gentleman who had a gross subluxation of cataractus lens. Almost 8 clock hours of subluxation was there. So let me show you some modified technique which I used to manage this case. The paracentesis was done. The gentle capsular access was done without causing much zonular disturbance. Make sure that you should be very gentle enough to cause much more zonular increase in zonular dehiscence. So completed with the capsular access forceps. Once you're done, the capsular hooks are placed in the area of zonular dehiscence. 2 capsular hooks were placed, one on either side, and gentle hydro procedures were done. And the phaco was continued and the chop was done. Relatively a soft cataract. Once you're done, the CTR was inserted to further stabilize the capsular bag. Then the cortical aspiration was continued and all the cortex was aspirated. Viscoelastic was injected to into the capsular bag. It is a 50 proline suture, polypropylene suture, passed through the clear corneal wound and got out through the 1.5 millimeter from the limbus. You can see the tip has been modified at bent at 2 millimeters from the tip to create a capsular hook. And you take an intrascleral bite of this 50 proline suture. Once you're done, using an end grasping forceps, bring it into the capsular rim and engage the capsular rim. And you can pull this 50 proline thread to stabilize the capsular bag. The second suture was passed and guided through a 30 gauge needle and brought it out 1.5 to 2 millimeters from the limbus. Pull the suture, pass it intrasclerally. Engage with the end grasping forceps and bring it into the capsular rim and pull it gently as much as required to stabilize the capsular bag. Once you have done that, a 3-piece multi-piece IOL was planned and it was placed in the bag. IOL was well dialed into the, and its centration was done. The viscoelastic was removed from the antechamber and as well as from behind the IOL. The ports were hydrated. Then triamcinolone was injected with the antechamber maintainer to check for the additional any vitreous which has been left over in the antechamber. Limited vitrectomy was done in the zonular dehiscence area. You can see the well-centered IOL. Now the scleral suture, the polypropylene suture is cut in flush with the sclera. So it is buried within the sclera without any exposure. Similarly, it was cut on the other side. So you can see a well-centered IOL. This is one of the modified techniques one can follow in subluxated cataracts, subluxated IOLs. Even for the iridodialysis repair, this 50 polypropylene suture is a very useful technique in management of these complicated cases. Thank you.
Very challenging case and very well done, Dr. Sunil. It's just that as we were discussing the earlier cases, which you must have watched, maybe making an incision at the site of the dialysis could have been avoided. And my other thought was, you know, like how do you manage the tension of the sutures so that, you know, you have not even cauterized the cut end of the suture finally, so that you make it little bulbous so that it gets stuck in that place.
No,
the suture could have got loosened up a bit and the IOL might not have been so centered, no?
The intrascleral course is too long, madam. So that's the reason why you need not cauterize the tip. If it has been a short intrascleral course, probably you need to cauterized to prevent the slippage of the suture.
Yes. So on to the expert panel, Dr. Rohit, do you have anything to add here?
It was a very good innovation. I had not seen it before. And so hats off to him, how he has managed.
Yes.
Basic points remain the same in managing, and how you fix and how you fix the back to the sclera is something where everybody has her own choice of doing things.
Yes.
We have Susan Jacob, who has her own clip technique, and all these techniques have come up. But I still stick to the CTR and a SUNIL ring for that.
Or a
matter.
CTS for that matter.
CTS.
Yes.
CTS, not a CTS.
For that.
Yes. Dr. Ramurthy, would you want to add anything here?
Very, very nice video. I mean, very
Yes.
nicely managed.
Yes.
Something different from what we have all used to. And
Yes.
as Rohit pointed out, there are various ways of managing the capsular bag, and this is one of the ways. I just used a slight variant of this for doing scleral fixation of intraocular lenses with an eyelet, where we have used a 50 proline suture, created a bulb both on the inside and the outside, and just fix the lens onto the sclera. I mean, I most often use an iris clip lens when I have to do a secondary implantation. This I found to be a very interesting technique where, hardly any much dissection had to be done. Just pass the suture on either side of the conventional eyelet of the scleral fixation lens and fix it. This was something different, a similar concept used for fixating the bag. I mean, something worth trying.
Yeah. Really amazing. Nice surgery.
Very innovative.
Very
Thank
innovative.
you.
So we,
Your point, I mean, both from the previous video and this, is that, I mean, I think we should avoid making the initial incision at the point of subluxation.
Yeah,
I mean,
true.
yeah,
I agree.
surgery is so much more easier.
yeah.
Agree.
The vitreous will not